I'll make it easy for you. I don't see a role for calcium scores in the future. It'll be inflammation first.
You're going to be seeing something, and you have seen something today, is a game changer. We're going to be thinking about lipoprotein-related risk and inflammation-related risk, and you're going to synthesize those together to decide what the patient's real risk is. This is the way to think about patients' risk because remember, plaque is the necessary precursor, but what lights the fire for plaque rupture is inflammation.
If you look into the natural history of coronary artery disease, you realize very easily that only 6.5% of the population will develop at some point in their life these obstructive lesions that cause ischemia and chest pain, angina. However, half of the heart attacks happen among those who never develop angina before they have the first event. And you can even go even earlier and find the inflamed artery because that's the artery that will give the plaque, that will give the heart attack later on. We develop a method that is called fat attenuation indexing that brings this hidden information on the surface from routine coronary CT angiograms and tells you whether an artery is inflamed or not. And in the most recent orphan study, we have seen that if you have high inflammation, then you have 10 times higher risk to die from a cardiac event over the next decade. Looking into comparing now the predictive value of high sensitivity CRP and Phi score, it becomes clear that the two are complementary. If you have systemic and local coronary inflammation, then you have a hazard ratio of 22.5 to have a fatal cardiac event over the next decade. And of course, when you add the one on top of the other, you get a significant improvement of the prediction, at least at the short term, within 2 years. High sensitivity CRP drops its predictive value as you move along after year 2 or 3.
Caristo is something like developing stage 1 cancer and treating stage 1 cancer and taking it out when you have that. Right now, cardiac CT is at stage 3 and stage 4 cancer. So this is very disruptive in how we think. This is the NCH Caristo partnership and workflow. We start with the CT scanner, submit the images to Caristo, we get the beautiful Caristo analysis, and then we generate our report.
What we as clinicians need to do is we have to figure out ways to both treat patients who have obstructive plaque and patients who have non-obstructive plaque or patients who have no plaque. But in fact, 80% of the patients who get coronary CT angiograms do not have obstructive disease. And for that reason, we need to know what to do with those patients. We also need to recognize that many patients with obstruction turn out to be non-inflamed. So these are the kinds of examples of things that you can actually do in your practice to change the natural history of this disease. And it's a very exciting time for those of you sitting in this room.